It's called the Big Ideas Biotech segment, but I got to break it to you. We're going to talk about health in general, and I've gotten the promise that all the speakers will at least say the word biotech in their talk. But beyond that, it's going to be a much wider discussion. We're going to go from the discovery in low-level science with Michael, who's going to talk about cancer. We're going to go through applications of these scientific developments about what happens when you aggregate really large amounts of information over millions and millions of patients to what can we learn from other medical cultures. And then we're going to back up from all of that and say, in the biotech industry and abroad, are there elements of knowledge that we should not address or that we should actually push away from in terms of the dangers they could present to us as a society? So we're going to start out with Michael Bishop, who is the university professor and chancellor at the University of California in San Francisco, winner of the 1989 Nobel Prize in Physiology or Medicine with his colleague Harold Varmus for the discovery of proto-oncogenes, the normal genes that can be converted to cancer genes by genetic damage. This work led later to the recognition that all cancer probably arises from damage to normal genes and provided new strategies for the detection and the treatment of cancer. He's going to speak with us about how to win the war on cancer. So please, Michael, thanks.
Thank you, Jeff. First of all, I like to think of high-level science, not low-level. Okay. And I'll make the point that biotechnology underlies everything I'm going to describe to you. We could not have done what I'm going to describe to you without biotechnology, and we would not have the future I will outline for you without biotechnology. So my big idea is we can win the war on cancer. Now, that's an audacious statement for at least two reasons. First of all, some very prominent figures in the press have been preaching that we're on the wrong track in doing research on cancer. Clifton Leaf, we're losing the war on cancer. Sharon Begley in the U.S. News & World Report last September. We fought the war on cancer, and cancer won. Well, I, for one, haven't given up. In truth, I think the picture is very different than that. The second reason that this is an audacious statement is the extraordinary complexity of cancer. Cancer is a disease with many causes. It affects every tissue in our body, and each tissue gives rise to a different kind of tumor, a tumor that is distinctly of that tissue and not of any other tissue. So this is not an easy problem to solve, and biomedical science has been trying to solve it, well, really since time immemorial. But there's been a breakthrough that has taken 3 decades to realize and which we are now exploiting as rapidly as possible. And that breakthrough is the realization that all of the complexity of cancer can be cut through with a single simplification. All cancer arises from malfunction of our genes. Now, I don't have time for a primer on genes, but I think the word is familiar to you, and I think it will suffice for me to say that genes carry the instructions that govern the lives of our cells. And if genes go bad, bad things happen. And that's exactly what happens in cancer. So, knowing that genes go bad in cancer, our objective is to know how many of these genes there are that go bad in cancer, in which cancers they go bad, how they function, and why they cause cancer and contribute to cancer when they go bad. Where do we stand at the moment? Well, through a kind of science that I would compare to hunt and peck typing, we've uncovered several hundred such genes that, when they malfunction, can contribute to the genesis of cancer. But the full Monty would be to have the complete inventory. And the only way we can get the complete inventory is to use sequencing of DNA, to analyze the sequence with which the little individual chemical units that compose DNA are put together. Now, you've all heard of the Human Genome Project, and that's exactly what was done. Human DNA, the entirety of it, 3 billion individual units, was sequenced, and we know the exact order in which those little units are arranged. And that allows us to decode the instructions that drive our cells. And if we look at those sequences in cancer cells, it allows us to spot the malfunctioning genes. The genes or the instructions are no longer telling the cell to do the right thing, but telling the cell to do the wrong thing. Now, the Human Genome Project took a decade and cost between $300 million and $3 billion, depending on who's counting and how they're counting. So, is it actually possible for us to do what we want to do, which is to compile a complete inventory of every malfunctioning gene in every form of cancer, and to compare those inventories one to another, and to use those inventories to address every facet of cancer, from prevention to cure? And the answer is yes. We've arrived at a point where the technology will allow us to do this. The improvements in our ability to ascertain the sequence of the component units in DNA, to decode DNA chemically, has advanced so dramatically that we can now do it, a complete human genome, in a matter of a few days for on the order of $60,000. And authoritative people in the field say that a $1,000 genome is just around the corner, and perhaps we can do it in a few days or even hours. That kind of technical advance is going to make it possible for us to decode, to create genetic fingerprints for every form of human cancer. The National Cancer Institute has recognized this capability by mounting an effort called the Human Cancer Genome Atlas, designed to compile these fingerprints for every human cancer. Now, this involves, someone computed, something in the order of 10,000 human genome projects or more. But the point is the technology now is there to allow us to do this. How will we apply this knowledge? We can use it in assistance with to assist what I consider the most difficult form of cancer research, ascertainment of cause. When we look at the genetic damage in a cancer gene, it can almost always tell us something about the nature of the causative agent. We have never had that capability before. It has been a guessing game before. Think of how few cancers we really know the cause for. Most lung cancer, skin cancer, cervical cancer, liver cancer in some instances, and that's about it. So we hope that this project, this sequencing capability to decode the abnormal genes in human cancer will help us ascertain cause. It will help us with early detection. There are extraordinarily sensitive techniques that allow us to find this genetic damage in the cells shed by our body, in our urine, in breast, in bronchial secretions, in feces. This is a brand new form of cytology, molecular cytology. It will allow us much more powerful prognostic capabilities. This is already in use at the bedside. Looking at genetic abnormalities in various forms of cancer has transformed, for example, the classification of breast cancer and is becoming a powerful prognostic device. It will allow us to identify the tissue of origin for metastatic tumors where we don't know where the primary is. It is that specific. And of course, it will allow us to create new therapies. It is already allowing us to do that. If we know a particular genetic malformation is responsible for a particular tumor, we can begin to devise therapeutics targeted at that abnormality in such a way that it will spare the normal cells of the body. Right now, we treat cancer with surgery and with poisons, either physical or chemical poisons, that wreak havoc with the entire body. These magic bullets that we can imagine now with this new knowledge will be of a very different sort. And we have one that's a poster child that many of you know about, Gleevec, which is a miraculous drug for chronic myelocytic leukemia, a curative drug with virtually no side effects. And we imagine that, and it is targeted at the genetic abnormality, the outlaw gene that we know is responsible for initiating this cancer. We should be able to do that for every form of human cancer in due course. We may even be able to personalize the treatment of cancer. We may be able to get the technology to the point where we can afford to look at the genome of every individual's cancer and tailor-make the therapy for that cancer. Now, where do we stand at the moment? Well, at first it's a little daunting because we know that most cancers contain dozens and dozens of malfunctioning or damaged genes. But there are certain core sets of such genes that typify one cancer from another, and it will be these core sets at which we will target or attempt to target our magic bullets. It's very early days, but we see the beginnings of a fulfillment of this dream, and Gleevec is just the first example. Herceptin is another example. It is not as magic as Gleevec, but is another example of such a targeted therapy, in this case, a malfunctioning gene in breast cancer. What are the prospects? Long term, we want to prevent cancer. I started my scientific career as a microbiologist. I understand how we more or less conquered infectious disease. We conquered it not with antibiotics, which have been a great therapeutic. We conquered it when we conquered it with vaccines, with prevention, smallpox, polio virtually, probably next measles. That's how we want to conquer cancer eventually, through prevention. But for the moment, what we need to do is to improve our therapeutics, and I've already outlined to you how this biotechnological approach of ascertaining the genetic fingerprints of cancer and targeting with magic bullets the malfunctioning genes, the outlaw genes, will offer new hope for therapy. And we will be able, at least, we hope, to turn cancer into a chronic disease like diabetes, or for that matter now AIDS, but ultimately, in many, if not all instances, to be able to cure the disease when we have failed to prevent it. That's my big idea. I think we can win the war on cancer, and I think we are on the right track. Thank you very much.
All right, thank you, Michael, for the high-level science. Much appreciated. Our next speaker is William Haseltine, who is president of the William Haseltine Foundation for Medical Sciences and Arts, a foundation that supports access to high-quality health care for the poor and middle class in developing countries, and that also fosters a dialogue between sciences and the arts. He's an adjunct professor at the Scripps Institute for Medical Research and has previously been a professor at Harvard Medical School and a chairman of Human Genome Sciences, Inc. He currently writes for the Medical Sciences and the Arts blog at The Atlantic, and he's going to talk to us about what we can learn from medical experiments in other cultures. Thank you, William.
Thank you. A good part of the conference has been dealing with the healthcare reform issues and a number of the political, social, and healthcare implications around those issues. From my perspective, many of these discussions don't go to the heart of the healthcare problem. As far as I can ascertain, the debate is more centered on reform of our insurance and our payment systems than it is of our healthcare systems. And if it is a debate about the healthcare system, it is only inferential in that payment may alter the way healthcare is delivered. So as far as I can see, the major debate that's currently going on at best can be seen as step one of a two- or multi-step process to improve our health. I came to the current work that I'm doing on analysis of healthcare systems in various cultures from a rather circuitous route. I've had a career in fundamental biomedical research. Mike Bishop was a colleague in the early days of retroviral research. I then moved through a series of biotechnology companies, created a company called Human Genome Sciences. And in that process of both looking at academic research and its translation into medical products, I realized that the system was broken at several points. One, the way we get ideas from universities to patients is non-functional. The biotechnology industry depends mainly on the pharmaceutical industry, and the pharmaceutical industry is misfiring in a major way. We are putting in lots more money, and we're getting many fewer drugs out. And so all of the wonders you've just heard Mike discuss, and anybody in science will discuss, have a very small channel for outlet to improve patient benefit. That's one problem. And in one part of my effort, I'm working on trying to change that paradigm. I think there's some good ideas for how we could change it. But there's also another problem, and that is, and I think a precedent problem, that is our healthcare system is becoming so wieldy, so expensive, that we now realize if we don't change something in a very dramatic way, we can't afford defense, we can't afford social welfare, we can't afford infrastructure. And these aren't trivial concerns. They're concerns that are expressed in a very clear form by the head of the Office of Management and Budget and others. And a number of people who look at macroeconomics have been aware of this problem for some time, but it's an onrushing problem that is not going away. It's only getting worse. And unless we restructure how we deliver health care so we get high-quality, accessible health at an affordable price, all of the wonders of cancer cure and cure of other diseases are not likely to be made available. And so that is a precedent problem. After I stepped down as head of a pharmaceutical company, I started looking around the world for places that were doing high-quality health care at affordable costs. And my travels kept bringing me back to South and Central India. Now, India is not the first place you would think about as a place where there is great health care. In fact, in most parts of India, that is not the case. Many of the rural districts are without any adequate health care whatsoever. However, it is a place where there is an environment of experimentation, and experimentation at scale. Many of the problems that we see with people experimenting with new healthcare systems is scalability. Well, in India, some of the healthcare systems that we're looking at deal with between 80 and 500 million people. And that's a reasonable scale to think about, solutions that may work for other people. The big idea that I have for this conference is to look at what is happening in the most efficient healthcare systems, where they're free to experiment, see what works to scale, and what can be imported to our own healthcare systems. So let me just give you a few examples. If you're interested in more of these examples, you can go to our website. It's, the foundation has a branch called Access Health Initiative. It's based in Hyderabad, India. The website is access-h.org. We've recently published, together with Results for Development, case studies on 40 of these efficient healthcare services. I'll just take you through a couple. We're all familiar with 911 and emergency healthcare systems. And by and large, they work reasonably well, not perhaps as rapidly as we want in all locations. But when we look at that system, we may not be looking at what's optimum. In India, especially in the state of Andhra Pradesh, and actually throughout India, there was no such number a couple of years ago. It just didn't exist. You had to call some local service if you wanted help. A software company, an outsourcing company, decided to address this problem, contracted Stanford University's emergency medicine department for quality, worked with McKinsey on management, used their own very established software technologies. At any one time, they had 200 software engineers working on this problem for a couple of years. And at the end of that time, came up with a system that they implemented for their state of 80 million people. Today, in that state, an ambulance is 16 minutes, no more than 16 minutes away from anywhere. Now, those of you who've traveled in India know that that's got to be some kind of major accomplishment. Because when I say anywhere, I mean the slums, I mean the congested cities where there are terrible roads, I mean the rural villages, and I mean tribal areas. And many of you may not think of India as having tribal areas, but it does. That's 16 minutes away from anywhere. Not only that, from the time the ambulance picks somebody up, there's a doctor on the phone from a central call service with the med tech. There's a separate operator on the phone in touch with the pilot who's driving that ambulance to get him around various obstacles, of which there are many in India. And they use very sophisticated software to analyze the results on a day-to-day basis, and it's a fantastic research tool. Well, that's been so successful, it's being rolled out now for 500 million people in a number of different Indian states. McKinsey estimates if we implemented the same centralized call system that is done there, we would save 200 times our cost. That's how efficient that system is, by using one call center. So it gives higher quality service. We can do that. We have the technology to do that. My personal estimate is the chance that we are going to do that is very low because we have such legacy systems. So we're in what my foundation and others are doing is trying to get those systems implemented in countries that don't have good responsive systems. And I think they will have better emergency care systems than we do very shortly. Another system that's worth looking at is one in which anybody with a mobile telephone in that same state can call in a central number and get diagnosed over the phone. And in addition to get diagnosed, if they fit most of the criteria, if they fit the patterns for most of the diseases that are prevalent, they can be prescribed over the phone. And the way they do that from a security point of view is either an e-prescription or they've built voice recognition for all the pharmacists in their state into the phone system so they can prescribe over the phone. Now, it's known in both the U.S. and in other contexts that about 80% of maladies can be diagnosed and treated effectively over the phone. And that is a very effective system for providing health care in areas. Now, how can that translate here in the U.S.? Well, we do that in West Texas, where there are very few doctors and a widely dispersed population. But we can do that from your own home. We can do that from other places. There are ways to implement that system here. And there are many intermediate steps that are going to be implemented and that we can see implemented in delivering high-quality health care at affordable prices. How about the other end of the spectrum, say bypass surgery? Well, there's a hospital system we're working with. In fact, there's several now, both in Karnataka and Andhra Pradesh, where we're working with hospital systems that deliver high-quality cardiac care. The metrics for those, and you heard, those of you who heard Victor Zhao talk, where that you can get, they provide a Westerner with a cardiac bypass surgery at about $8,000, a savings of about 80%, over 80% to 90% of what is charged in the U.S. They will provide an Indian with that service at considerably less cost. Well, how do they do that? And what are the outcomes? Well, in many of these hospitals, and I want to stress that these are experimental. This isn't what happens everywhere in India, by no means. But in these hospitals, those doctors do 10 times more cardiac surgeries a year than they do in the US, Europe, or Japan. How do they do that? They're organized to be more efficient, and they work more days than our surgeons do. The result is much better use of overhead equipment, much better use of hospital facilities, and it turns out a better outcome. They also do something that our surgeons generally don't do. They generally don't use heart-lung machines. They train their surgeons to a higher degree of specialty to work on beating hearts. You may have followed the Indian Prime Minister's second bypass surgery. It was a 10-hour surgery. If you tried to do a heart-lung machine for 10 hours, it would be very difficult. He wouldn't have a brain left to direct the Indian national policies and products. So, in fact, they do a higher outcome, better health. There are many examples of that. The idea that I have is we should start looking at the most efficient systems around the world. And don't only talk about payment reform. Talk about structural reform and how we can import the most efficient practices that lead to a high-quality, accessible, affordable outcome here in the United States. Thank you very much.
Thank you very much, William. Our next speaker is Gary Puckrein, who is a PhD and a preeminent authority on health information products. Currently the executive director of the National Minority Health Month Foundation, which he founded almost 10 years ago. Under his leadership, they have launched the Zip Code Analysis Project, which is a database that links vital statistics, demographic statistics, many patient statistics, over 500 million patients in one single index organized around zip codes. He serves as the executive director of the Alliance of Minority Medical Associations, and he's going to talk about what we can do when we have that kind of aggregated information.
Good afternoon. Big idea, to get to it in a word, is in the same way that we have a stock market that measures the movement of the economy, or a weather system. We need a health monitoring system that monitors health status for the U.S. population as close to real time as possible. We started building that back in 1998. When I grew up in the Walter Cronkite era, just that 1-2 channels. And Walter Cronkite would end his show with a statement about the economy. The stock market went up, the stock market went down. And I always felt, well, money's fungible. What I really want to know is how many people died today, what did they die of? And in 1998, I had the good fortune to begin working on that project. We've collected zip code level data for the U.S. population, and we really do know where chronic diseases manifest themselves. And I'm going to give you just some top-line learnings that we found from operating in that database, because I think it gives us a sort of particular view of American health. Diabetes. We've got now about 18 million diabetics in America, living in 38,000 zip codes. 80% of all the diabetics in America live in 8,000 zip codes. 80% are in 8,000 zip codes. We look at those as diabetic communities. Now, why they're there, we don't know. But we do know that the disease is localized in 8,000 zip codes. We recently launched an HIV Atlas. For the first time, we went to all the states and collected the data, unfortunately with HIV because of the controversy around the disease still. We collected it at the county level. There are about 3,200 counties in the United States and the county equivalents. 80% of all the HIV is in 200 counties. Again, highly localized. End-stage renal disease. The federal government pays about $27 billion a year on end-stage renal disease. 80% of the incidence of end-stage renal disease is in 2,000 zip codes. Every year. Absolute same zip codes. That's why DaVita can build a dialysis center in that community, because there's a market there for it. What we've started to learn from all of this is that there are stable consumption patterns around the country for healthcare. There are stable markets. There's a diabetes market. There's an end-stage renal disease market. That market stability is driven by the incidence and prevalence of chronic disease, same population in the same geographical area, getting the same illness year after year. It's also informed by how patients respond to the disease. I have a touch of diabetes. I have a little hypertension. Everybody around me has hypertension. And it's also informed by how the healthcare financing system responds to it. So when you put all those things together, it creates what we would call stable consumption patterns. We would argue that understanding those stable consumption patterns puts you in the place of being Walmart, because now you know your customer. And what you really want to try to do is anticipate your customer's need before they get there. So let me give you an example, a precise example of what I'm talking about. Medicare. So we've gone in and we've looked at Medicare with diabetes. Today, there are 7.5 million diabetics in Medicare. We went and we clustered them into 5 consumption groups based on how much Medicare was spending on that population. One group, my staff always says, we prejudiced it by calling them underutilizers, but the lowest spend that Medicare has on this diabetic population, it's about 50% of all the diabetics in Medicare. Medicare spends about $1,400 a year on their care. Anybody who knows anything about diabetes knows you cannot spend $1,400 a year on anyone's care and have good outcomes. But that's what's going on in Medicare right now. Those patients, about 18% of them, the next year their cost goes up 1,000%. Every year, like clockwork. They jump up into another group that we call crisis consumers. Their Medicare is spending somewhere around $125,000 a year in their care. That happens one year, and those costs come down about 51% the following year. I'm talking about absolute stability in these patterns at the zip code level. I'm giving you national numbers, but I'm telling you, you can drill those numbers down to the zip code. We also think in looking at these numbers that within small geographical areas, we are seeing genetic expression. For us, when we look at the data, we look at, there's a group of physicists who describe human beings as self-replicating information systems. And that's kind of how we look at human beings, self-information, replicating information systems. And we look at this data as output statements from those self-replicating information systems. And when we look at them, what we're saying is you can intervene. You can actually intervene and drive down cost and improve quality by knowing exactly where the market is and beginning to anticipate what those patients' needs are. Right now, we're in the process of mapping MRSA. Whole conversation about MRSA and growing numbers of incidents of MRSA. It expresses itself at the zip code level, and hospitals don't like to hear that, but the fact of the matter is it's fairly consistent at the zip code level. Cancer, once again, if you think about genetic risk, the way zip codes are set up, you can begin to tease out genetic risk at the zip code level for cancer. And why does that become important? I think one of the reasons why we hesitate around personalized medicine and everyone sort of dances around this very important movement towards personalizing medicine is because we think the market is going to be unstructured, that it's going to be a lot of onesies and twosies that we'll have to try to figure out how to handle. And what our data is saying is, no, they're going to get clustered pretty quickly into markets once we begin to understand how we link genetics and geography in the country. So here's where we are. We've started to put this data out over the internet. We've been working with a lot of advocacy organizations right now because they need good data. And so we've been putting this data out over the internet. Where we're going and where we think the country's going. We have to have an information system now. We're in the 21st century. I hear all this conversation about how we need all this health technology, and once we get it, we'll do this. We have it. We can do it right now. And once we put that in place, I think we'll be able to intervene. My personal prejudice at the end of the day is I think that the real contest is what my physics friends would call reversing entropy. That's what we're really about. That's the conversation that we really need to have. And I understand right now we like to do a lot of talking about money, and that's important. But I think if we use the systems at hand, we can solve the money question and build a real 21st century healthcare system. Thank you.
Thanks, Gary. Thank you. Our final speaker is Alta Charo, who is the Warren Knowles Professor of Law and Bioethics at the University of Wisconsin Law and Medical School. She is a member of the Institute of Medicine and has served on the NAS Board of Life Sciences and IOM Board of Population Health, helping to draft reports on the FDA's drug safety system, the ethics of transnational AIDS trials, preventing terrorist use of biotech research, and managing the smallpox vaccine program. She co-chairs the National Academy's Human Embryonic Stem Cell Research Committee and helped draft its national research guidelines. She was a member of the NIH Human Embryo Research Panel and President Clinton's National Bioethics Advisory Commission, and more recently served on the HHS review panel for President Obama's transition team. She's going to speak, we're going to go back to bioethics for the end of this, and she's going to speak about, are there certain types of information that are forbidden or should be?
Thank you very much. I had imagined that by this moment you would have been regaled with tales of all the new and wonderful things biotechnology is going to do for you. But I have to confess, I like these talks better. My training began in biology and moved on to law, but while I was still doing biology in the early and mid-1970s, I had the privilege of taking courses from E.O. Wilson, famous for his book on sociobiology, where his work on the study of ant colonies led him to speculate about the biological and evolutionary origins of the behavior of women. And it led to just a small amount of controversy, including calls from some very reputable people in the biological sciences and elsewhere, that his research simply shouldn't be done because it is so potentially socially harmful or disruptive. And regardless of what I thought of his theories, I did find myself struck by this call that the research itself and the knowledge itself, or at least the hypotheses themselves, should not be explored. It led me to think about some of the other scientists in history who faced this kind of reaction. Let me here just give you a small quote from Galileo, something he wrote in the margin of his own copy of the Dialogue on Great World Systems. He wrote, "And who can doubt that it will lead to the worst disorders when minds created free by God are compelled to submit slavishly to an outside will, when we are told to deny our senses and subject them to the whim of others, when people devoid of whatsoever competence are made judges over experts and are granted authority to treat them as they please. These are the novelties which are apt to bring about the ruin of commonwealths and the subversion of the state." Now, of course, Galileo, we all know, was threatened with excommunication merely for endorsing the Copernican view that the Earth, and by extension humanity, is not the center of the universe. And so perhaps he would not have been surprised in 2006 when the Vatican threatened to excommunicate any scientist who did research on purely laboratory aspects of cloning, somatic cell nuclear transfer, or other aspects of embryonic stem cell research. Because, again, there was a concern about the understandings that might develop. But I have to say that at least in the case of the Vatican, it was accompanied by a genuine theologically grounded belief that we were talking about preventing harm to concrete individuals, in that case, embryos. But there were similar calls for the criminalization of cloning research in particular, one example of biotechnology, that came not only from the Vatican, but from both sides of the aisle, right and left. And for the secularists who called for these bans, who led to what turned out for me to be a series of talks called From Stem Cells to Jail Cells, to talk about the experience of our scientists in several U.S. states. For the secularists, it was not about protecting a concrete individual or about a belief in the status of embryos. It was really about a fear of social disruption, a debasement of humanity, or a slippery slope towards some application of which they disapproved. And so it was really much more akin to the earlier Galilean Vatican efforts to stifle research that challenges a fundamental cultural or political or theological belief. And so the big idea I wanted to offer for today's lunch period is this: that biotechnology is likely to continue throwing up examples of research and knowledge that will challenge our most cherished political and theological and cultural notions, that will terrify us, and that will lead us to call from both left and right, secular and religious, for a ban on the very research itself, lest the knowledge it develops be used incorrectly or somehow undermine the moral fabric of society, whether it's the creation of human-animal chimeric combinations, or it's synthetic biology's possible move toward the creation of biobricks for off-the-shelf construction of organisms that will live and maybe in the future even breathe. All of these will tempt us to call for a ban on the knowledge and the research, and the big idea I have is that we should resist that we should protect biotechnology from that kind of reaction, and that we should consider trying to develop a political and cultural, if not constitutional, theory of a right to do research. From my perspective as a lawyer, I often look to the Constitution, at least for inspiration, and the First Amendment, as we know, protects freedom of speech, as well as assembly and association. Now, freedom of speech is not merely the freedom to say things. It covers all kinds of expressive conduct. Those people around the world this week who are wearing green in sympathy with those who are protesting the elections in Iran are engaged in speech by virtue of a green color symbolizing a particular political point of view that is effectively communicated by a behavior. And so, while scholars have every once in a while very tentatively asked whether research should be protected as free speech because it's a precursor to actual speech, like writing an article, I think that a more fundamental approach to this question is to ask whether there are times where research itself, the very decision to ask a question and explore the answer in the laboratory, is a form of conduct that expresses a political or theological or cultural point of view, whether because the scientist pursues it for that reason or because those of us who observe the research and its publication have that message sent to us. Research on the origin of the species, such as Darwin conducted, for example, could be implicitly viewed as conveying a message, one that is still disruptive today. The message being that we can reject many of the extant religious views about the singularity of humans and substitute a worldview in which we are part of a continuum in the animal world, rather than being a singular creation separate from it. Indeed, according to Goethe, Copernicus's research about the position of the Earth and the Sun had exactly that effect on this notion of the singularity of human beings. Goethe wrote, "Of all the discoveries and opinions, none may have exerted a greater effect on the human spirit than this doctrine of Copernicus. The world had scarcely become known as round and complete in itself when it was asked to waive the tremendous privilege of being the center of the universe. Never, perhaps, was a greater demand made on mankind, for by this admission so many things vanished in mist and smoke. What became of our Eden, our world of innocence, piety, and poetry, the testimony of the senses, the conviction of a poetic religious faith?" And then he concluded by saying, "No wonder his contemporaries did not wish to let all this go, and offered every possible resistance to a doctrine which in its converts authorized and demanded a freedom of view and greatness of thought so far unknown, indeed not even dreamed of." So here, in the modern world, we have a series of discoveries that have rocked this same notion of the singularity of humankind, the origins of life, or even the meaning of life. Whether it's the synthesis of artificial chromosomes, using cloning to mimic natural fertilization, combining human and non-human cells to form hybrids and chimeras, they all challenge what one commentator called human exceptionalism, which for some people is the bedrock of human rights, and what Leon Kass, the former head of President Bush's Bioethics Council, called the very meaning of being human. More recently, research into enhancement, sometimes called transhumanism, using neuroelectronics and drugs, has been singled out as a threat to our species and an avenue towards a world in which our very humanness has somehow been diminished. So to do this kind of research, one might argue, is to implicitly convey the message that you reject the idea that the meaning of being human is something that is fixed, unchanged, beyond dispute, and beyond exploration. Now, I'm not going to try to argue that the U.S. Supreme Court in its current or future configurations is likely to adopt this particular view of the First Amendment, and nor do I want to suggest that this would mean, if we were to take up this argument in any fashion, political or constitutional, that there are no appropriate limits on research. We do, in fact, limit all kinds of conduct and, in fact, all kinds of speech with reasonable restrictions that are needed to guard against concrete harms, whether it's a harm to the environment or it's a harm to a research subject. If somebody's engaged in synthetic biology research that threatens to develop a wholly new pathogen against which we have no protection, there is a perfectly appropriate and legal basis on which to put protections around that research. But that is a far cry from a call to criminalize research simply because it upsets us, it bothers us, or it undermines our particular views of God, which certainly has been the basis for many of the calls of criminalization that have come from the right of the political spectrum, and to some extent, while not calling it religious, but limiting it to spiritual, has underlies the calls similarly from the left. Slippery slope arguments and speculation about harm and dual-use issues where the same discovery could be used for both good and evil similarly form an inadequate justification for criminalization and prohibitions on a mass scale, while they do nonetheless form a wonderful argument for regulation and appropriate restrictions in order to keep the honey but avoid the sting of the bee. Now, I don't want to leave you with the idea that excuse me, that every form of research has this kind of flavor. Certainly in the years when I was unsuccessfully beginning a career as a scientist, none of my research had any political content. There was no expressive conduct in many of my failed organic chemistry experiments. But there is a subset of research that really does touch on these things that are very close to our hearts and close to our homes that I think needs to be carved out for a very special form of protection, because no matter what our politics, we do seem to have this moment, all of us, when faced with something we find profoundly disturbing, to reach out and say there ought to be a law. And I'm simply saying that we ought to slow down before we say there ought to be a law. And let me just conclude by saying that those from the political left and from the political right, in my view, who are calling for this increased attention to the social control of science would be well advised to consider the words of Thomas Jefferson, one of the founders of the Enlightenment theory of our country, who said, "Liberty is the great parent of science and virtue, and a nation will be great in both in proportion as it is free." Thank you.
Thanks very much, Alta. Do we have time for questions? How are we doing? Yes, any questions? Please.
I'd like to ask our zip code.
Oh, sorry, we have mics coming to you right now, so people can hear.
Jan Hamilton, PhD in nutrition, and you can imagine we always look at causation. With your zip code work, would you suspect there are any environmental toxins, xenobiotics, pollution factors that are affecting disease in those area codes?
The honest answer I'd have to say right now is that I don't know, but I think the data is, I was listening to the conversation earlier this morning, and it's quite clear the data is available. You could know pretty quickly whether there's a correlation.
I'm an LSU graduate, a PhD at Pennington Biomedical Research Center, and then Georgetown for a postdoc. I was told when I went to LSU that I was going to Cancer Alley. So I'd like to know, at that mouth of the Mississippi River, do you find that to be one of the zip codes?
Yes, they're down at the lower part of the Mississippi River, Louisiana. They call it Cancer Alley, and there are lots of theories about why it is, but yes, the answer is yes.
Who's going to do that data collection then to tell us something about the zip codes where we can learn something about causation and then prevention?
We are right now working on mapping cancer. So we're pulling together the data right now and starting to analyze. And we produce maps, and they'll be online, I would suspect, by the end of 2009, early 2010, they'll be online.
I'm impatient today. Thank you.
All right, on this side.
Yeah, I have a question for Dr. Puckrein as well. With the work that you're doing with the zip codes, I'm assuming you're using prescriber data to get some of the information, and I know in some of the states we're legislatively seeing the bans on prescriber data, so how that was affecting your work.
I have to confess that we've been at the data collection war for a decade, and data is siloed in a lot of places. And I think the prescriber data conversation makes no sense to me whatsoever. First of all, a lot of it is being built around the assumption that pharmaceutical companies are using prescriber data in order to sell branded products. 70% of all drugs are generic. So if that's what they were doing, they failed miserably at doing it. It's absolutely important now, and this goes back to the whole question of bioresearch, that we've got to get over these ideas about how we limit access to information because it is going to cost us lives and money. We have the capacity to know now, and we have to know. Otherwise, we are going to ration care because it's going to get very expensive, and you see the warning signs coming. So I would strenuously argue that we need to get transparency in the system. The American public needs to know. They need to know where the diseases are, what are the therapies that are being used, what are the outcomes. They got to know all of that, and you should be able to go to your internet and pull it down and absolutely know what's going on in your community. And I think it'll create a lot of it'll eliminate a lot of the problems. So long answer because it's a special problem that we face in getting access to information You would think that with an infectious disease like HIV, that you would get a warm reception when you want to track that information. Very, very difficult to do. Took us almost 2 years just to collect the data itself. But there are lots of other, even diabetes, and it's not readily available.
Any other questions? Right there.
This is a question for Mike Bishop. When you were talking about the promise of the Cancer Genome Atlas and how far being able to understand the causation of cancer will take us towards therapies, I was sort of thrown back to the promises we made in the early days of the Genome Project, and I'm wondering sort of how you balance the explanation of the promise with tempered reality of that very long road ahead. In other words, I'm concerned about overpromise in the Cancer Genome Project, much like we overpromised with the Human Genome Project.
Well, I would take issue. You may think that we overpromised in the short term, but the payoff from the Human Genome Project is far from complete. First of all, it's playing out in the cancer realm. All right, and so I think it's unfair to say that Human Genome was a waste of time and money. There may be payoffs that extend over generations to come. We had to start with that fundamental piece of information. In the case of cancer, we can point to palpable outcomes already of understanding the genome of the tumor cell. But we'll never get there with Hunt and Peck research. We've got to do a comprehensive analysis of the genomes of all the human cancers. And that's why I stress the fact that this is becoming a technically reasonable thing to do. With the reduction in cost and time required to sequence the genome, say, of one cancer, it's becoming a feasible thing to do. And that knowledge is most certainly going to inform how we think about the origin of cancer, the detection of cancer, the treatment of cancer.
I did not, by any stretch of the imagination, call the Human Genome Project a waste of time. In fact, I spent much of my career involved in it. I was rather sort of pointing to the issue of the time, because it is a long time horizon from being able to make a diagnostic, able to understand the molecular pathways involved in disease etiology, and then being able to develop that magic bullet. And I just think that sometimes we get so excited about the discovery phase that we mislead, perhaps, the public about how fast and how slow this will happen.
Well, I didn't predict when all this would happen. I had 10 minutes. I outlined the big idea, why I think in the long term, we're not going to conquer cancer in my generation. I'm 73. We're not going to conquer it maybe in my children's generation. President Obama made that statement about stem cell research, which I thought was really admirable when he signed he said, we must do this research even though even our children's generation may not see the ultimate benefit from it. It may take yet another generation. So given 30 minutes, I would have laid out all the caveats about how long this is going to take. But if we don't start it now, we'll never get it done. And we can start it now. We're well along, actually.
William.
Let me just underscore, it takes a long time. I founded Human Genome Sciences in 1992. We found some interesting genes in 94. We understood what they might do in 98. We began a call for lupus with one of those in the year 2000. Just last week, we found that in a phase 3 clinical trial, it seems to work. That is a long time, but it is a payoff, and I think it's the first of many that will come from what Mike has described as not Hunt and Peck research, but systematic genome-based research. That is going to be a payoff for those patients. Hopefully there'll be many, many other such examples, but it takes a very long time, and you are correct to point that out. And I think Mike has sort of clarified that point admirably as well.
All right, I think we have time for in the back.
Okay, I just wanted to follow up with Bill Haseltine. In the beginning of your remarks, you talked about some of the concerns with the pharmaceutical industry, and you talked about some of the you've been working on in terms of patient benefits. I wonder if you could talk a little bit more about that.
I think it's well known, many in the industry, that the pharmaceutical industry has some structural flaws The main flaw is that it's got so big, the big industry, the big part of the industry, big pharma, that in order to make any difference to the sales of the company once products go off patent, they have to have drugs with total sales of $1 to $2 billion before it's even considered. That's a very high mark for any new discovery to make right out of the box. And in fact, it's so high that people fail. Most projects are abandoned. Many projects are distorted. I call it a reverse Cinderella syndrome, where you put a small discovery into a big shoe, and it's a big marketing shoe, and they very often fail. And if they don't fail and they're introduced into the market, they're withdrawn for side effects. So it's a model that has proved to be unworkable. The biotech industry, on the other hand, has been very, very good at getting new ideas up and running into the clinic, but is usually under-resourced and undermanned, and except now for the very largest biotech companies, almost which don't exist anymore. One of them was just purchased by a big pharma company. They have to feed into the big pharma model, and most of their drugs are killed. And anybody who's in the industry has seen that happen over and over and over again. So we have to restructure that model. I think there are ways to do it in which you create a series of smaller companies with fungible knowledge platforms that access technologies that are currently available for every aspect of pharmaceutical development outside of a pharmaceutical company by contract. And I think there are ways to do that so you can now develop drugs for their best indication, and if they happen to have wider application, do it that way. But the industry must go through a major restructuring if we're going to take advantage of all the knowledge that we have. Again, to go back to Kathy's point, things take a lot longer. I thought the industry would realize this, but they're still making tons of money. Their margins are huge, and I think this very newest generation of CEOs is beginning to realize that they have to do some radical restructuring. You see that in companies like Sanofi, Aventis, but they're doing it in a sort of an odd way. They're going generic, and they've decided to abandon a lot of their research and go generic, and that's not necessarily good for anybody. I think it's necessary, but somebody, sometime, maybe in a better economic environment than we find ourselves in, will figure out how to do this restructuring on a systematic way. I think it's possible to do. It should be done. Let's hope it will be done.
All right, we're out of time. Thank you to Mike, Larry, and Alta. Thanks very much.